If you're a nursing student or a new grad, holding a syringe of high alert medication at the bedside can make your hands shake. That hesitation is actually a sign of a healthy respect for the drug you're holding. Insulin is a powerful metabolic regulator. Misunderstanding the pharmacology can trigger a rapid, life-threatening crash, but getting it right can pull a patient back from a total metabolic crisis. I'm Brooke Wallace, a 20-year ICU nurse and clinical educator. My goal here is to bridge the gap between NCLEX theory and actual bedside reality, so you know exactly what to do when you're standing in front of a real patient. Take a second to subscribe to the channel and check out supernurse.ai for clinical resources designed to support your practice. Transforming that bedside anxiety into clinical control starts with looking under the hood. You have to understand the invisible chemical chain reactions insulin triggers inside the body. Let's start with a common clinical hurdle: preparing a single syringe that contains both a fast-acting regular insulin and an intermediate-acting NPH insulin. This microscopic view of cloudy NPH insulin shows an adic protein called protamine. They act like heavy weights attached to insulin, slowing absorption. But if accidentally pushed into clear, regular insulin, free protamine molecules jump ship, actively detaching and aggressively binding to the fast-acting insulin. By doing that, you have chemically converted the fast-acting insulin into intermediate-acting insulin. The rapid onset properties of that entire vial are completely destroyed. This physiological reality is exactly why we strictly follow the clear before cloudy sequence. Drawing the clear, rapid insulin first ensures that no heavy protamine proteins ever contaminate that fast-acting vial. The structural properties of insulin also dictate how we treat emergencies. If a patient is crashing and needs an intravenous push, there is an absolute rule: only regular insulin can be given through an IV. This comparative line chart shows the absorption curves of different types of insulin. Look at the steep trajectory of the rapid-acting molecules. Because they don't clump together, they absorb almost instantly, creating a massive, near-vertical spike in activity. Because of that speed, there's a dangerous temptation at the bedside. You might think about injecting rapid-acting insulin early just because the cafeteria called and said the patient's food tray is on the way. If that tray is delayed by even a few minutes, the medication hits the bloodstream without any new food digesting in the stomach. The insulin violently sweeps all the existing resting glucose out of the blood and forces it into the cells. As a result, the patient's blood sugar completely crashes. Therefore, you never administer rapid-acting insulin unless the patient is physically capable of swallowing and the food tray is sitting actively in front of them. Continuing with this chart, let's zoom in on the apex of the curve. This is the peak. It is the precise pharmacological window where the medication is exerting its maximum force, pulling the absolute highest volume of glucose out of the vascular space. If a patient hits this peak without enough sugar in their system, you will see a distinct physical presentation. They will start sweating heavily, their heart rate will spike, and their hands will shake. Their blood sugar has dropped below 70. Those symptoms are actually a survival mechanism. Neurons in the brain cannot store their own energy. When they sense the glucose supply plummeting, the central nervous system panics. It triggers a massive fight or flight response, dumping adrenaline into the body to force the liver to release stored sugar. When you see this in a conscious patient, you implement the 15-15. You give them 15 grams of simple, fast-acting carbohydrates, like 4 ounces of juice, to generate an immediate rescue spike in their blood sugar. But that simple sugar digests quickly and will burn right off. You must follow it up by providing an anchor of complex carbohydrates and protein, like peanut butter and crackers. This slows digestion and provides a steady release of glucose to bridge them safely to their next full meal. Recognizing the timeline of the drug's peak allows you to anticipate the brain's panic response. You intervene early, stopping a simple hypoglycemic dip from escalating into an unconscious emergency. Now, let's look at what happens when the metabolic engine completely derails. We face 2 severe emergencies: diabetic ketoacidosis, or DKA, and hyperosmolar hyperglycemic syndrome, or HHS. In both cases, the blood sugar skyrockets hundreds of points above normal. This cross-section of a blood vessel shows the critical mechanism driving both crises. The massive excess of glucose acts as an osmotic diuretic. It forces the kidneys to excrete huge amounts of urine, dragging the body's water out with it. The vascular system is left severely dehydrated, and the remaining blood becomes thick and syrup-like. The most fatal mistake a nurse can make right now is to immediately hang an IV insulin drip to fix the high blood sugar number. The insulin will open the cellular doors, and because water always follows glucose, the tiny amount of fluid left in the bloodstream will violently rush into the tissue. This instantly collapses the vascular bed and sends the patient into hypovolemic shock. The ironclad rule for both DKA and HHS is fluids first. You must complete aggressive intravenous fluid resuscitation to physically refill the vascular tank before you ever introduce insulin. Clinical mastery comes from anticipating these physiological shifts before they ever trigger a monitor alarm. When you understand the underlying chemistry, the initial bedside fear is replaced by a precise, calm control over the patient's care. To download our clinical roadmaps, master your NCLEX exams, and own your practice at the bedside, head over to supernurse.ai.